So I'll introduce Ryan Hoy, who's going to give our next talk. Ryan graduated from the University of Melbourne in 1998 and completed his physician training in 2006 and then undertook a fellowship in Toronto in occupational medicine. And he's going to give us an update on some of the areas where he's particularly skilled in practices in occupational medicine. He holds a visiting position at the Alfred Hospital and is a research fellow at Monash University. Thank you very much for coming across, Ryan.
Thanks, and thanks for the opportunity to talk. And I think from an occupational health point of view, Hubertus, it's better to take the stairs rather than jump off the stage. So we don't want you tripping and breaking a hip or something. So I'll be talking about occupational causes of lung disease. I'll give you a bit of a snapshot about what occupational lung diseases are, some of the causes of occupational lung disease, and then focus on two quite topical issues at the moment, which have really increased awareness about occupational lung disease at a political level as well as a union level and various other levels as well of late. And just touch on how to identify some causes of occupational lung disease also. So we've got to remember with our patients, those that are currently working, they spend a lot of time at their workplaces. So over an average week, so a 7-day week, our patients will spend about a quarter of their time at their workplace. And so over years and years, this is a really substantial amount of time that people are spending in that environment. And so over a typical working week, the respiratory tract will be exposed to 18,000 litres of air. So a very large amount of air. And if you have a job that requires some exertion, then that volume is going to increase quite markedly. So really we've got to remember that air quality at work is a major determinant of respiratory health. There's a very broad range of causes of respiratory disease. You know, we all think about asbestos and really don't think much beyond that often. So there are some that are really well known, but others that are quite obscure. So for example, with sensitizer-induced occupational asthma, which is one of the most common occupational lung diseases worldwide, most respiratory specialists would know about baker's asthma, which is caused by exposure to wheat flour at a bakery. But as I said, there's about 300 known causes of sensitizer-induced occupational asthma, and they range to things like octopus. So as a seafood process worker boils octopus, it releases an allergen which can cause sensitizer-induced occupational asthma. So there's a really broad range of causes. There are some that we've known about for hundreds, if not thousands of years, so such as silica. But then there are always new causes of occupational lung disease, and a really good example of this is the volatile butter flavouring diacetyl, which is used to develop the buttery flavouring smell in microwave popcorn. And in the United States, there was an outbreak of quite severe OB as a result of exposure to this volatile agent. And it was only through the work of some really switched-on physicians that worked in the region that they linked it back to a particular factory where all these workers were exposed to diacetyl. And diacetyl was actually used in other food processing industries, and even in the coffee roasting industry, there is exposure to diacetyl and potential exposure that can result in conditions like OB. Latency is important to think about when we look at causes of lung disease. There are some exposures which will immediately cause respiratory problems, such as if a cleaner spills ammonia at a workplace, that exposure may immediately cause irritant-induced occupational asthma. The first responders to the World Trade Center disaster, the highly alkaline dust that they were exposed to caused immediate respiratory problems. But then there are exposures which have a very long latency. So asbestos is obviously the classic example of that, where problems may not manifest for 20, 30, 40 years after exposure. When we think about occupational hazards, we do need to think about the nature of those hazards in terms of what aspect, what part of the respiratory tract is affected. So gases and vapours, we think about their water solubility. So those that have high water solubility affect the upper respiratory tract, so things like hydrogen chloride or chlorine, whereas those with lower water solubility will affect the lower respiratory tract, so like nitrogen dioxide. And then particle size is really important too. So when we're thinking about dust, we're most concerned about respirable particles, so those particles that are 5 microns in size or less that can then enter the lower respiratory tract and have adverse effects there. But what we've got to remember is with respirable particles, they're so small that they're actually not visible in the air. So just because you can't see dust in the workplace doesn't mean that respirable particles aren't actually present. So there's a really broad range of occupational respiratory conditions, and these are not historical diseases. These are diseases that you're likely to be seeing in your practice very frequently. And any part of the respiratory tract can be affected by occupational exposures, starting from the nose, going all the way down to the pleura. So occupational rhinitis can both be allergic or irritant. One of my areas of interest is in laryngeal dysfunction, so irritable larynx syndrome, vocal cord dysfunction, and how it's differentiated from asthma. And in particular in the workplace setting, it can be very difficult to differentiate laryngeal dysfunction from work-related asthma. And so when I was in Toronto, we undertook a study where we assessed all workers with work-related asthma presenting to our clinic, and we identified that about 25% of them actually had laryngeal dysfunction as a cause of their work-related symptoms rather than it being asthma. So a really substantial proportion of workers. Work-related asthma is now the most common occupational lung disease in industrialised countries. So 15 to 20% of 15 to 20% of adult onset asthma is actually caused by occupational exposures. So a really substantial proportion. COPD is often not thought about in terms of occupational contribution, but 15% of COPD is also caused by occupational factors. There's a wide range of interstitial lung diseases caused by occupational exposures, which I won't go through in detail, but I will touch on a couple of those as we move on. And obviously cancer as well, lung cancer. In men, some recent work from Lynn Fritsch's group in Western Australia identified that potentially up to 35% of lung cancer in men is associated with occupational exposures. So we always think about tobacco, but we really need to think about occupational factors as well. But unfortunately at the moment we have very, very limited insight in terms of the actual occupational lung diseases that are occurring in Australia. We don't know what the emerging problems are, we don't know what the causative exposures are or the industries where these are occurring. So you might think the workers' compensation data provides us a lot of information, but it really provides very, very little information. When you actually look at the data that's published by workers' compensation organisations, they report things like other respiratory diseases due to substances. So, it's not information that actually can be used to focus interventions and assess how effective those interventions are. And if you see a patient with a lung disease that's caused by an occupational exposure, at the moment there's really limited avenues for you to report that. So you may report that to the workers' safety regulatory agency in your state, but how they actually act on that information is very unclear. Other countries do this much better than we do. In particular, the United Kingdom have been running a occupational lung disease surveillance program since the 1980s, and they publish this comprehensive publication every year, so on occupational lung disease in Great Britain, and it provides a wealth of information about the diseases that are occurring and what the exposures are that are a problem. We did run for a very brief period of time a surveillance program called SABRE. This was through Monash University, where occupational and respiratory physicians would report cases of occupational lung disease. So it provided a brief insight into the conditions that those physicians were seeing, and asthma was the most commonly reported occupational respiratory condition at that time. We do have a lot of data about mesothelioma through the Australian Mesothelioma Registry that is tracked very, very closely. So our data about mesothelioma is very good, and this is a really good review that was published in the MJA earlier this month, so from Bill Musk and colleagues. So I'd really recommend you have a read of this, and it does show that the trend in terms of mesothelioma now has plateaued, and it is likely to start slowly decreasing. But we're still fourth in the world in terms of our age standardised mortality for mesothelioma based on our high per capita usage of asbestos in the past. So coal mine dust lung disease, so black lungs. So This is a topic that really gained a lot of media attention from issues in Queensland of late, and has really put a spotlight on some occupational lung disease issues. So Queensland was internationally held up as a great example in terms of their control measures, because no case of black lung had been identified in Queensland for about 30 years. So it was a bit of a shock when the first case was identified in 2015, and this was also identified by a very astute general practitioner who's got a background experience in occupational medicine. And the worker, well, the patient had actually been diagnosed with sarcoidosis, but through a proper assessment of his occupational history and thinking a bit further, actually identified this was actually coal workers' pneumoconiosis, not sarcoidosis. So following that identified worker, then there were many others that were identified soon afterwards because of increased awareness through the involvement of one of the unions in Queensland. And that triggered a major review of the dust control measures in the Queensland coal mines, as well as the health surveillance system too. So coal mining has changed markedly over the last several decades. So this is a historical picture of what a coal miner might have been doing. But this is the modern coal mine environment. And so in Queensland, the coal seams are over 60 metres underground, so it's mined through an underground mine method. In Victoria, we have mostly brown coal, which is much closer to the surface and is open cut mining. We've had other problems in Victoria, such as with the Hazelwood coal mine fire about 2 years ago that caused a lot of issues in terms of the local residents in that area. But with underground mining, typically they use what's called longwall mining, and there's this massive tool that cuts across the mine face, and as it cuts, the coal is then dropped onto a conveyor belt and then is shipped out of that the coal face. And then you can see up the top here the roof structure, which is bolted in and then moves forward, and then the roof collapses behind as the drilling tool moves forwards. So you really need to understand that this is an environment where there is a potential for high-level particle exposure through that cutting process, but also as dust is disturbed, such as the movement of the conveyor belt or as vehicles move through that area. But when we take an occupational history of a coal miner, it's really valuable to ask them about what their job actually entails. So just because somebody says they're a coal miner, that doesn't mean that they actually work down at the coal face. They may be doing some other job. So there's a really wide range of duties and varied tasks that come under the banner of being a coal miner. But the highest level of dust exposure certainly is at the coal face. And coal mine dust is a very complex mixture. It's not just coal dust itself. There's often a high level of silica depending on the local geography of the area, or geology I should say. There are silicates, there are volatile organic compounds, but there's also machinery in there, so diesel-powered machinery will generate diesel particulates. There's often microbial bioaerosols. Chemicals are used, such as diisocyanates, in the process of bolting the roof to the area, which is a well-known cause of occupational asthma. And there's a range of lung diseases that are potentially caused by coal mine dust exposure, not just black lung, so coal workers' pneumoconiosis, but also COPD, in particular chronic bronchitis, and they're really struggling at the moment in Queensland in differentiating workers that present with chronic bronchitis as to how much is potentially caused by smoking history versus by their work in the coal mines. So simple coal workers' pneumoconiosis, at this stage a worker is asymptomatic. It's characterised by small nodules, varying number of nodules, the ways of classifying that, but essentially the nodules have to be less than 10 millimetres in size. And then as the condition progresses, then you develop what's known as progressive massive fibrosis, as those nodules coalesce, they group together, and they're greater than 10 millimetres in size. But obviously in this situation, it's a much more profound involvement in the upper lobes bilaterally with significant loss of volume. And then again, on CT scan, we see some pretty obvious features of progressive massive fibrosis with large areas of nodularity present. But as I mentioned, in the early stages of CWP, workers will have no symptoms. So that's why it's really important to have health surveillance in place to pick up problems early before they go on to develop more significant lung disease. And there's varying recommendations internationally about how this should be done, but in Queensland it was done by a nominated medical advisor, and there would be chest x-ray, lung function and a medical questionnaire performed pre-placement of that miner, and then annual questionnaires, annual spirometry, and then chest x-ray every 2 to 5 years. So you sort of wonder why there was problems, since they had quite a reasonably well-structured program. So I was involved in review of the health surveillance scheme, and so my component was with Professor Bruce Thompson, who's the head of the respiratory physiology department at the Alfred Hospital, and Bruce and I reviewed the process where the spirometry was being performed, and we reviewed 256 spirometric results. And what we found was that most of the testing was performed by nurses, which is completely fine. But the problem was that only a quarter actually performed more than 20 spirometry tests for the scheme per month. So really infrequent performance of the testing. So, as we know from experience working in respiratory labs in large hospitals, in our labs, they'd be performing potentially 100 per day rather than these sorts of numbers. And only 42% of the nurses had actually attended a training course. And those that did say they had attended, often they couldn't actually recall what the name of the training course was, so it was a little unclear as to whether that was completely accurate or not. And out of the 256 spirometric results, we evaluated 102 of poor quality and would be rejected in an accredited lab. So, we would find results like this, where there's obviously a clear cough during the forced expiratory manoeuvre, or insufficient inhalation also prior to the forced expiratory manoeuvre. So very poor quality for a large proportion of them. And then less than half were actually accurately interpreted and reported. So it was for these reasons that the program wasn't picking up problems. And I won't go into the chest x-ray results in detail, but they also found several cases of evidence of pneumoconiosis based on proper reporting of the films by a specialist radiologist that weren't being picked up through the previous review process. So many systematic failings in terms of identifying problems with these workers. So silicosis is another lung disease which is not a historical disease. This is an active problem in Australia and internationally. Silica is everywhere, so silica accounts for 59% of the Earth's crust. Silica exposure can result obviously in silicosis, which is a chronic fibronodular lung disease, but it's also associated with COPD, tuberculosis, connective tissue disease, renal disease, and lung cancer. And historically, the workers that would be mostly exposed to silica dust would be cutting through stone in its natural settings, so a miner or a quarry worker or a tunneler. So Sydney's essentially built on sandstone, so Sydney has a very strong history when it comes to silicosis. But what we've been very concerned about recently has been the identification of workers with a severe progressive form of silicosis known as accelerated silicosis in the building industry. And this is in workers that manufacture kitchen benchtops, so what we call kitchen benchtop fabricators. And what these workers are doing are they're cutting slabs of artificial stone to be inserted into kitchens, as we can see here. They cut the slabs to size, they cut out the inserts for the sinks and for the tapware. So the problem primarily is with this product, which is what's known as artificial or engineered stone. And this is an extremely popular choice now for kitchens and bathrooms. So anybody that's renovated recently would have likely put in this type of stone. This is not a rare boutique type stone. It's known as Caesar stone, Esser stone, Siler stone, Smart stone. There's companies in India and China that are also producing it currently. It's a relatively new building material, only been around in Australia since the early 2000s. It's very cheap in comparison to natural stones. and it's available in a wide range of colours, which is why it's so popular. But what is artificial stone? Essentially, the producers crush rock and make that rock to a very, very fine consistency. They mix it with a type of resin, and then it's compacted into these slabs. And the issue with that is that it has an extraordinarily high silica content. So the silica content of artificial stone slabs is over 85% crystalline silica, whereas in comparison to marble, it only has 2% silica, or granite about 30% silica, and those natural stones are the ones that benchtop fabricators in the past have been more used to using. So the awareness of this level of silica in this type of product is very, very poor. And so as workers cut through these slabs, they are potentially exposed to extraordinarily high levels of respirable silica. There's very little information at the moment about this level of exposure, but this is one study that was done looking at types of engineering control measures to reduce dust generation. And the recommended limit for a 30-minute exposure to silica is that it shouldn't exceed 0.3 milligrams per metre cubed. And when even using water and this tool, they were getting levels of 10 times over that standard. And then when dry cutting was performed, which is what a lot of these workers do, as I'll show you in a moment, they were getting levels of well over 100, 150 times what that standard is. And that's just only over a 30-minute period. So really extraordinarily high levels of silica. So what's generally recommended with this product is that it's done by robotic cutting. There's a lot of water that's used, that it's not done in an environment where an actual worker is, so it's isolated from the workers, so potential silica dust generation doesn't actually affect that worker. But what actually happens is that workers will do this sort of activity, and this is what patients have described to me, that they will use hand tools, they'll cut it without any water at all, and very high levels of dust that's generated. And you can see a worker here cutting out the insert for a sink to be placed in. This was another scary thing I saw on the internet. So this was a recommendation about how to stop dust affecting the rest of the building site if you need to cut stone on site. So you can see the two guys here and then sawing away. And you know, it's just mind-boggling that this sort of thing. This was on YouTube actually. I found this recommendation. So in terms of the workers that we've seen over the last 2 years, these workers have been in small industries, so small workplaces. So between two, one had 20 workers in there. Many were from overseas that had only been in Australia for 5, 10 years or so, and had poor English and weren't members of unions. So really were restricted in terms of their knowledge about occupational health and safety issues and support generally. But one of the main concerns was that they've had very short periods of time where they've been working with artificial stone products. So normally with silicosis, we'd expect it over about 10, maybe 20 years of work or longer, whereas these workers have been developing symptomatic silicosis over 4 years or more, so really short period of time. And very rapid loss of lung function over periods of follow-up. So with a mean of 503 mils of vital capacity loss per year. So extremely fast lung function decline. And to the point now that one of these workers has undergone a lung transplant in Sydney, and then 2 in Victoria are under consideration, and there are others that are likely to be heading that way quite shortly. And we can see radiologically what happens as well. So this is one of the cases that fortunately we had some x-rays or CT scans to refer back to. And we can see in the early stages here a patchy ground glass infiltrate. And then as time's gone on, we start to see a little bit of nodularity developing, which is consistent with early simple silicosis, but still in a background of that ground glass infiltrate. and then development of more coalesced nodules, a bit more fibrotic change, and then some more of the classic nodules associated with progressive massive fibrosis. So very rapid radiological progression as well. So it's not the cover of Nature, but this was the front page of The Age yesterday. And so we've really been advocating through the Thoracic Society and the Lung Foundation to increase awareness about silica dust exposure in the building industry. And we were fortunate enough that one of the journalists of The Age took a significant interest in the story and ran it on the front page of The Age yesterday morning, and it was picked up on in the one in Sydney is. I can't remember what the equivalent of the Heritage City. Yeah, that's right. And so we've had quite a bit of attention on this issue recently, which has been very helpful, and hopefully it'll result in awareness and some action from regulators. So it's important as respiratory physicians that we always maintain a high index of suspicion that our patients may in fact have an occupational cause of their lung disease, especially if it's a new onset disease, if there's uncertainty about the cause of their disease, if they work in a higher risk industry. For example, if you work in a bakery, if you work at a pet shop. Pet shops have a zoo of allergens present there that can cause occupational respiratory allergic problems. But occupational exposure may also exacerbate pre-existing lung disease. So if you have asthma and then exposed to irritants, that may worsen asthma control. And we're very concerned that these recently identified workers with silicosis are the tip of the iceberg, because those that have milder forms of silicosis, so simple silicosis, won't be symptomatic yet. And so really we want every respiratory physician to keep an eye out for these workers when they are referred, and to notify me preferably, but other colleagues that have an interest in occupational respiratory disease. And we really have an important role here to advocate for our workers, to identify occupational causes of lung disease, and to really assist where we can. So it's important for everybody to really ask your patients, what kind of work do you do? Don't just ask for a job title, ask them actually what they specifically do for work. Try to describe your work for me, what you actually do on a day-to-day basis. So these are two textbooks that I really recommend that every respiratory physician should have in their library, on their bookshelf. So Park's Occupational Lung Disease is a new edition of this that has just come out this year. And the other one as well, Occupational Disorders of the Lung, has also come out, I think, as a new edition recently. But very, very helpful textbooks to go back, when you've got a bit of uncertainty, very helpful in terms of providing some guidance. So thanks very much. That could be like maybe a stocking stuffer for Christmas this year.
Thank you very much, Ryan, for that excellent talk. I think we've got about 5 or 10 minutes just to have some questions and discussion. I'm sure there would be after both of those. We can start off over here.
Ryan, thank you very much. Pete Allcroft. Do you think we've missed the boat using FEV1s? Is there something on the horizon that's more sensitive, easy, cheaper than CT scannings? It's a blunt instrument, really.
Yeah, absolutely. Certainly spirometry and chest X-ray are both very blunt tools. There has been some guidelines recently that have been published looking at CT and trying to correlate that with the current, what's known as the ILO standards for identification of early features of pneumoconiosis. But the problem at the moment is that these workers are scattered throughout the country. They're in very remote places often. So it's the access to those sorts of testing, which I think is pretty much the limiting factor. If the workers could come down to a big place like Brisbane and have their testing done then I think we would be looking towards CT scanning. But the issue there also is that we're likely then to pick up small nodules, and we don't really know what the meaning of that is in this workplace, in that workforce. So there really needs to be be a lot more done in terms of the best mode of surveillance.
I've got a question in relation to the silicosis fibrosis. Is it known whether that responds to nintedanib or pirfenidone? Is there a shared mechanism or is it a divergent mechanism?
Yeah, there hasn't been any studies done that I'm aware of that's actually looked at therapeutic trials. I know that certainly with this problem, there are many researchers that are keen to do that work, both in Australia and internationally too. So we had a session discussing this at the ARS in Milan recently, and certainly it's a concern in the United States as well as in Europe too. So hopefully internationally we may be able to get that sort of trial up and running.
Sebastian.
I'm out of curiosity, I'm asking about that case which you said sarcoid was misdiagnosed as sarcoid. Is it getting misdiagnosed as sarcoid-like reaction, granulomatous, or?
I'm not sure the exact details of that case. That's what's been that I've been informed of in terms of what actually happened. I think that it was more. I don't think that worker had a histological diagnosis of sarcoid. I think it was based on the chest radiology, and he's in that news story. You can see him holding up his chest X-ray, and he has sort of bilateral upper lobe nodular change, and I guess radiologically, it may have been a reasonable differential to think that it was sarcoidosis, but I don't think he had a biopsy performed.
Ryan, Jason DaCosta, thank you very much. Pardon the pun, but at the clinical coalface, these patients are often very difficult for us in clinical practice to sort of nut out. You'll often see elderly patients with some upper lobe nodules, maybe some lymphadenopathy. We do EBUS on them, we find anthracolitic pigment and say, oh, this is sort of, occupational related exposure from your past job. But then we also see, symptomatic patients who tend to progress. We see patients who come in with asthma, and they tell us that they think it's the workplace causing it. I have no idea in most workplaces, even though I try and take a detailed history, what they're actually being exposed to at a sort of chemical or, product level. Is this where you come in? I mean, do you get sort of specialist referrals to?
I do, yeah. So I get referrals from other respiratory physicians, from occupational physicians, from work cover, from lawyers, a range of sources. But I think it comes back to our training, and I do provide a lot of talks through Monash University to our medical students, to our trainees in Victoria as well, about taking an occupational history to sort of look for clues for occupational causation. But you don't need to be an occupational hygienist, have an understanding of all the different agents to make a judgment as to whether you feel that it is actually caused by work. I think what we need to remember is that as respiratory physicians, you're the expert, and as long as you're actually considering an occupational cause, for most of the time, that's actually sufficient. But you should, if you are going to make a diagnosis of an occupational lung disease, refer to a textbook, refer to a guideline. At the moment, we're in the process of developing guidelines for diagnosis and management of work-related asthma for Australia. There are guidelines that are produced through the ACCP, through ATS, ERS, so there are international guidelines you can refer to as well. What state are you from? From here. So I'm not sure, in terms of Adelaide, who you might be able to call upon for assistance in terms of occupational lung issues. Hubertus, you don't know? Oh, that's a worry, okay. Oh, that's terrible. Yeah, every state's different in terms of the way the work insurance process works. Yeah, in Victoria, we go to a independent review process if there's differing opinions about that. So,
I wrote a report on someone who for 37 years engraved metal, stone, glass, and inhaled it from 5 centimeters distance. And the counter report was from a gastroenterologist who said it was utter bullshit and it could not have possibly caused the lung disease. And they got an independent one from Victoria, and then they lost the case. That was good. So thanks for giving us great reason for not to do any more coal mining, from a medical point of view. When my kitchen got renovated 4 years ago, and of course Australian planning and measurement, the Caesar stone didn't fit. So they walked in the front garden with the Caesar stone. I followed them, and I found 2 blokes in a cloud of white dust, trying to make it fit, not wearing anything. I said, should you be doing this? Is it healthy? Yeah, should be all right, mate. Yeah. So that's the problem. So how far are we away from a register, notifiable disease register, and maybe make the mining companies pay for it?
Yeah, we've been pushing pretty hard through the Thoracic Society. So a lot of the problem comes back to occupational health safety issues being state-based rather than being a national issue. So it's something that we're still advocating for quite strongly.
Most workplaces have like a HAZChem type of, with the chemicals that are used. Are they ever useful in this setting if you wanted to find out what chemicals a person's exposed to?
Yeah, so every chemical substance at a workplace has, by law, needs to have what's called a safety data sheet, and that safety data sheet then contains the name of the ingredients in it, and then some basic toxicological information about that. So it's helpful to ask the patient to bring in the safety data sheets for the substances that they're using, and then when at least you know the name of the substance, then you can have a look online. The CDC in the States, has this site called ToxNet, and that's a really helpful resource then to look at some other information. So there's a lot of really good information online if you actually get the name of the actual substance that's present.
One problem with that process is that some companies, for some processes, namely fracking, have the right to suppress, as a proprietary secret, suppress the names of the chemicals, so you'll never find out. Yeah.
Okay. I think in the interest of time, we better draw the discussion to a close, but if you could all join me in thanking Professor Gersman and Dr. Hoy for excellent talks and very stimulating start to the day.